Welcome to Ultrasound Physics and Knobology. The purpose of this online module is to provide the foundation necessary to obtain high-quality images. Ultrasound has been in use in medicine for over 60 years and is currently one of the most widely used diagnostic tools. Historically, ultrasound has been the domain of radiologists, but thanks to the emergency medicine physician, that domain has broadened with the revolution of point-of-care ultrasound. Now, ultrasound-guided vascular access and thoracentesis is considered standard of care all over North America. The availability of handheld or portable ultrasound devices able to produce excellent image quality while being user-friendly has made ultrasound's transition for use by the intensivist practical. But like flying a plane, being unfamiliar with the technology can cause a lot of stress. However, after this session, ultrasound physics, transducer manipulation, and image adjustment will come second nature to the operator, just like flying a plane, or riding a bike if you prefer. With point-of-care ultrasound, the intensivist is in the unique position of having to operate the equipment without technical support available, obtain images for immediate need while the patient is crashing, and be able to interpret these images in real time and apply it clinically to influence management of the patient. I cannot stress the importance of understanding what all the knobs and dials do because as the Intensivist-Sonographer, you have to 1. Operate the equipment, 2. Position the patient who is uncooperative, or at best, unresponsive, being careful not to dislodge any critical lines or tubes, 3. Manipulate the transducer to obtain necessary images while all the time assuring safety of the patient, troubleshooting technical failures, and interpreting the images you obtain. Oh, and yes, you will be expected to do this all with one hand, because your other hand is holding a needle getting ready to perform a procedure guided by your ultrasound images. So to outline this module, we will start off with ultrasound and image composition, then move to the knobology so that you can become familiar with optimizing settings, and finally, discuss ultrasound assumptions which can lead to the production of artifacts. There are 3 main principles in ultrasound physics that are very useful in understanding image composition, and therefore in optimizing those images. These 3 principles are signal attenuation and signal degradation, the trade-off between frequency and wavelength, and how setting up gain and depth affect the image on the screen. We will now go over these in some detail. Attenuation is the term used to account for the loss of wave amplitude as it travels through medium, due to all mechanisms which include reflection, absorption, scattering, loss of heat. Ultrasound, originally used in World War II to figure out the depth of submarines below sea level, is applied to medicine in the same way. That is, we use the time it takes an ultrasound wave to reflect back to us to determine the distance between us and the reflector. So, the main principle of using medical ultrasound is to detect reflected sounds. Here, the strength of the reflection matters too. Stronger reflections are considered brighter objects than weaker reflectors. A uniform medium does not reflect much sound. It's the difference in the sound transmission properties within the tissue and between tissues what makes sound reflect back. The bigger the difference in sound properties between 2 structures, the larger portion of sound reflected. Since each tissue medium has a usual specific sound property called acoustic impedance, the bigger the difference in acoustic impedance between 2 tissues, the brighter the boundary will appear on an ultrasound image. Looking at the table here, you can quickly see that if lung or bone are present next to other tissue, you should expect a bright line to form at the border. But it's not only the boundaries between tissues that reflect sound. Since body tissues are not perfectly homogeneous because of fibrous tissue and blood vessels, tissues do not have a discernible structure within them, making them appear in different shades of gray. The standard or generic tissue in the body, the tissue that is used for reference, happens to be the liver, namely the non-cirrhotic liver, because cirrhosis makes the liver look more white, or more echogenic than normal liver. Now, since we see reflections best when we are perpendicular to the reflector, if the transducer is held at any angle to the boundary, you will lose much of the reflections and will not see the structure as clearly. Note in the diagram this non-90 degree angle has resulted in a reflection beam that is never received by the source. Other ways ultrasound energy is lost when it does not return to the transducer include scatter and absorption. Scatter is a distinct form of reflection that happens when the sound wave is reflected in multiple directions, rather than back to where it came from. The difference between reflection and scatter is that scatter occurs when a beam hits a curved boundary, and the radius of this curve is smaller than the wavelength of the beam. This happens when a beam hits RBCs, or small granularities within tissues, for example. Scattered is different from what happens when a beam hits a large curved boundary, such as a cardiac chamber or the hemidiaphragm. Large objects will reflect sound rather than scatter it. The third way ultrasound is lost in the body is through absorption, which is the conversion of sound's mechanical energy to heat. Absorption is a common final pathway of being lost in the tissue. Eventually, all the ultrasound wave that you put in the tissue is converted to heat and is absorbed by the body. And this is the first principle of ultrasound, the answer to the question of, where does it go? However, not all ultrasound is absorbed the same way. Different tissues absorb ultrasound differently. Each tissue type has an acoustic absorption coefficient. This coefficient tells us how unfriendly each tissue is to an ultrasound beam. The higher the number, the more unfriendly the tissue is. See how the numbers are different by tissue type? Water and blood are really ultrasound friendly, while bone seems to stop ultrasound in its tracks. Also, because the amount of attenuation of ultrasound depends on tissue characteristics, the distance the beam travels, and the frequency of the beam, higher frequency ultrasound beams are absorbed faster. On the other hand, low frequency ultrasound can travel farther before it dissipates into heat. Therefore, high frequency ultrasound probes can only show you superficial structures and cannot be used to visualize deeper structures. Now, when the image on the screen is generated using shades of gray, the darkest shade indicates low number of return echoes, and the brightest areas indicate a high number of echoes returning from underlying structures. So, a large pleural effusion will appear as dark areas with nothing filling the space, and a diaphragm, which essentially functions as an ultrasonic mirror, will appear bright white on the screen since most of the ultrasound waves are reflected back from it. Structures in between these two extremes can be seen as hypo, iso, and hyperechoic to the standard middle-of-the-line structure in the body, the liver parenchyma. So what happens to ultrasound when it hits air? You get A-lines. This known air artifact is used in lung ultrasound, where you see multiple horizontal lines deep to the pleural line representing reverberations of completely reflected sound between the skin surface and pleural line. Typically, you cannot see past air. And what happens to ultrasound when it hits fluid? You see a black area with clear view behind it. Therefore, fluid is considered a great acoustic window. And what happens to ultrasound when it hits bone? You see a white leading edge, then shadow behind it. Again, just like air, you cannot see past bone. And what happens to ultrasound when it hits soft tissue? You see gray layers and boundaries. You will lose some of the energy, but some will still be transmitted through. Which brings us to the second principle of ultrasound, which is the trade-off between frequency and wavelength. It so happens that the product of the frequency and wavelength of sound results in its speed. Because the speed of sound in soft tissue is considered to be a constant at 1,540 meters per second, which is not exactly right, but for now, just think of it as a true constant, then increasing wavelength means decreasing frequency, and decreasing wavelength means increasing the frequency. We already know that higher frequency means faster absorption, therefore less penetration. But smaller wavelength also means less scatter, which is better. There is, however, another advantage to smaller wavelengths, and that is smaller wavelengths have better axial resolution. Axial, also referred to as longitudinal resolution, means what is the smallest distance between two objects that the beam can resolve as two objects. Therefore, a smaller number will mean better resolution. The axial resolution distance calculation depends on the wavelength and the number of cycles in the beam. Therefore, smaller wavelengths will have better resolution. That is to say, using a higher frequency transducer will give us better axial resolution, allowing us to separate structures even when they are very close to each other. Therefore, there is a trade-off between frequency and wavelength, makes it necessary to use different transducers. and different frequency settings for different applications. If we use high-frequency transducer, such as a vascular probe, we expect to have more absorption, therefore less depth, but also we expect to have less scatter and higher resolution. On the other hand, if we use a general abdominal probe or a phased array cardiac probe, we should expect to have better depth penetration, but the images are not going to be as sharp due to scatter off of smaller structures, in addition to poor resolution between adjacent structures. This is the second principle of ultrasound, the one size does not fit all principle. Now we come to the third ultrasound principle, gaining depth. Like we said earlier, the machine calculates the time it takes an ultrasound wave to reflect back to us to determine the position of the reflector. The machine then places the reflected signal on the screen with brightness value relative to the loudness of the signal received. But ultrasound loses energy as it travels through tissue. A smart machine knows that reflections from deeper structures will usually return as weaker and more quiet signals. Therefore, current ultrasound machines will adjust the brightness assigned to each reflection relative to the calculated distance traveled and relative to the frequency of the beam. This adjustment in brightness is called time gain compensation, or GAIN for short. This compensation allows for each tissue type to appear uniform, and allows for tissues of similar acoustic impedances to have the same gray tone relative to each other. The way the image is gained can be changed as well by the operator. However, louder is not always better, because loud signals carry less information. The reason is diffraction. Diffraction is the widening of ultrasound beam that happens farther than the focal point of the beam, usually deeper in the tissue. This widening limits the ability to distinguish objects that are side by side, or the lateral resolution. Lateral resolution is generally poorer than axial resolution is dependent on beam width. As the ultrasound machine assumes that any object visualized or originates from the center of the beam, then two objects side by side cannot be distinguished if they are separate by less than the beam width. The determinants of beam width are 1. Transducer frequency. A beam width increases as the frequency decreases. 2. Focusing of the beam. This is achieved both mechanically and electronically. 3. The gain, where increasing the gain will increase the beam width and reduce resolution. Therefore, to optimize lateral resolution, you should 1. Use the highest frequency transducer for the application needed and not at the expense of penetration. 2. Optimize the focal zones, if those are adjustable on the machine. And 3. Use the minimal necessary gain, which means scanning is best done in a dark room. Now, for location of echoes to be determined, the transducer has to transmit a signal, or talk, part of the time, and to receive or listen to echoes most of the time. The way a 2D image is formed is by sweeping waves across the sector. The transducer sends out pulses side by side from the probe face, and the transducer waits to receive the returning echoes, listening about 99% of the time. So the density determines the lateral resolution of the transducer. The more lines transmitted per frame, the higher the lateral resolution. But as you can see in this image of a cardiac probe, and unlike the case of linear vascular probes, cardiac probes that are called phased array probes tend to shoot the beam in a cone-shaped pattern. This allows for better imaging between the ribs where the imaging window is narrow, but also results in lower line density at deeper areas and therefore low lateral resolution. Now the returning signals are plotted and the plot is constantly refreshed for real-time imaging. The number of times an image is refreshed per second is called the frame rate. Imaging of movement organs, for example the heart, need to be refreshed 25 to 50 times per second for an image to appear as live. Otherwise, the image will appear choppy and will be called to have poor temporal resolution. The ways you can improve temporal resolution is by setting up the machine to allow the formation of full frames in less time. This can be done by 1. Minimizing depth, that is, minimizing the maximum distance from the transducer that you want to show on the screen. 2. Narrowing the sector of the area of interest. And 3. Minimizing line density, but that will only happen at the expense of lateral resolution. Now, let's go back to the transducer for a minute and recap what we heard. Ultrasound beams are created by transforming electrical activity to pressure waves. This is called piezoelectric effect. It's known to naturally occur in quartz, but zirconate titanate crystals were found to be better than quartz and are currently in use in commercial ultrasound transducers. When electrical current is applied to the crystal inside the probe, the crystal vibrates, causing an ultrasound wave creation. A backing material, also called the dampening layer, stops the crystals from continuing to vibrate, and a matching layer is positioned in front of the crystal to lower energy loss by minimizing changes in acoustic impedances between connecting surfaces in the path of the ultrasound wave. Sound reflections from tissue interfaces return and hit crystal, which in turn vibrates, creating electrical current. And as you know, the amplitude of the reflection determines the brightness of the signal, and the time it takes a reflection to return to the probe determines the location of the reflector on the screen. It is important to know that very high voltages are needed to produce diagnostic ultrasound. This voltage can pose a risk to the patient and to the operator if the ultrasound transducer is damaged or cracked. But other than that, ultrasound is pretty safe, right? If it's good for a baby, then it must be good for you as well, right? I would have thought so if it was not for the thermal index, called Ti, and the mechanical index, called Mi, usually reported on the screen. Ti represents the ratio of acoustic power produced to the power required to raise tissue temperature by 1 degree Celsius, and Mi, on the other hand, is an estimate of likelihood of cavitation in tissue, also called histotrypsy, where tissue is mechanically fractionated, resulting in tissue necrosis. And I wouldn't have believed it if I didn't come across an article in 2012. It described how high-frequency ultrasound can be used as a potential male contraceptive in mice, using only 2 sessions, each for 15 minutes, with a 2-day pause in between. After reading this, I try to make sure I don't leave the probe on the patient's body while I go looking for a gel bottle when I run out. Now for a little bit of flow measurement principles. Christian Doppler wrote his thesis on the apparent change in the color of light emitted by binary stars that rotate around each other. He never thought his name would be imprinted on every ultrasound machine in hospitals in the future. Otherwise, he would have trademarked his name. And just like Doppler described with light emitted from stars, the principle of Doppler in ultrasound is the same. When a beam hits a moving reflector, the frequency of the reflected sound will change. This change in frequency allows us to calculate the speed of the reflector. Simple and straightforward? However, for the relationship to work, the beam should hit the moving boundary head-on. Otherwise, the speed of the reflector will be underestimated. But by how much? By the cosine of the angle of the incidence, that is, the cosine of theta. That's why the police can only underestimate your speed when shooting their beam at you from the side of the road at an angle. And if you try to argue your way out of a ticket, be aware that most police officers are familiar with Doppler's equation principle and with the values of cosine theta. So, Doppler ultrasound can be used multiple different ways. It can be used as a continuous Doppler, power Doppler, and as color Doppler. All modalities will allow you to assess speed, but with power Doppler, you'll be able to assess the speed and the location of the moving object. And with color Doppler, you'll be able to assess the speed, the location, and the direction of the flow. However, with power and with color, the accuracy of speed estimate is compromised to allow for the additional features. Now, that is all we will discuss in relation to ultrasound physics. Let's talk about the technicalities of using the ultrasound probe. Here we will discuss how to manipulate the transducer to the correct orientation, how to choose the right imaging mode, and how to adjust the gain and the depth for optimal image acquisition. The rest of machine settings, including zoom, focus, frequency, power, gray maps, harmonics, and recording images, will not be discussed in particular, because they do not vary between machine types. But don't be shy of discovering all these options on your own. First, the transducer. One thing is uniform between all transducer, and that is the marker. Every transducer has a marker that corresponds to the marker on the screen. The transducer marker may be a dot, a line, a groove, an illuminated bulb, or a ridge. However, there may be more than one marker on the probe, and that can be confusing. So touching the face of the transducer and looking for movement at the surface of the picture is not an unusual way to determine marker orientation every time you are handling a different probe. This is not unusual, and we advise that you use the finger technique before you start using the probe. And this is important because you want your marker to be pointing towards the patient's head or towards your left side at all times. So here in this image, the green dot on the upper left side of the screen points toward the patient's head. The top of the picture is the most shallow area under the probe, and the bottom of the picture is the most deep part of the scan. When you stick to this convention, a uniform image orientation is displayed all the time, and other image reviewers can figure out your orientation without confusions. This way, using the term long axis means that the probe is in line with the long axis of the body, with the marker towards the head. When you do a short axis scan, your probe marker will be oriented to your left, or the subject's right side if you're facing the patient. However, the terms long axis, or sagittal, and short axis, or transverse, may be used in reference to the orientation of the organ or area scanned rather than the patient, such as the case of a vessel, the internal jugular, in these images. Again, why is it important to stick to the rules? Try to read this chest x-ray. I'm sure you can. However, it will take you much more time than reading it when it's usual orientation. The same rule applies for ultrasound images. You can interpret the image best when it's in its usual orientation. This allows for less confusion, and for familiar orientation to be to your advantage. Now for the transducer hold. The two standard transducer holds are the pencil hold and the remote control hold. You will need to switch back and forth between these two hold methods while scanning. The advantage of the pencil hold is that you will have a lot of freedom to manipulate the transducer in space and to change its angle, tilt, and rotation. The advantage of the remote control hold is that you can exert pressure when pressure is needed to diverge soft tissue and to get to the area of interest in obese patients, for example. And it's usually a more relaxed hold if you're scanning a low area relative to your standing position. But holding the probe is never correct until you get your hand anchored to the patient's skin. In these three examples, the red arrow points to the anchoring point, which does not need to be wide or prominent, as long as you can feel movement if the patient or the transducer are shifting relative to one another. And after you've held the probe and placed it on the skin, hopefully with some gel in between, you need to place your free hand on the machine dials. Here, the first thing you need to do if the image is not what you expect is to find the 2D button, the gain dials, and the depth button, in that order so that you can adjust the image on the screen. The 2D button will get you out of any prior image modality and reset everything back to baseline. The gain dials, as you expect, will control how brightly an image is presented on the screen. Notice that there may be 3 dials for gain adjustment. The top dial will control the near field gain, a middle dial will control the far field gain, and a lower dial will control the overall gain. The depth buttons control the shown image depth on the screen. That is, they control if the image needs to be more shallow or more deep. Here, the top image is too shallow, and the top right image is too deep for the organs of interest, which is in the area between the liver and the kidney in this case. Now, if you need to find the colored Doppler or M mode buttons, they are usually located near the 2D button and are labeled so. To go back to standard imaging from any of the special modes, all you need to do is to push the 2D button again, and that will take you back. The main reason for artifact creation in ultrasound images is the presence of assumptions within the machine calculations that may not be what happens in real life. Some of these assumptions include that the speed of sound is the same in different parts of the body. This, of course, is not true, because there is no generic soft tissue that is uniform in composition. Another assumption is that reflections occur only at 90 degrees from reflector and that reflections are always generated by reflectors that are in straight path of the beam. And in the case of Doppler, the assumption here is that the moving structure is at 0 degrees with the beam. Of course, there is no realization of time gain compensation before the images are processed, and the temporal resolution is assumed to be perfect by the machine and that images are generated without any lag. You can see how all of this can result in some usual misunderstanding between the user and the images generated. For example, tissue that is deeper than strongly attenuating objects, such as calcification, appear darker because the intensity of the transmitted beam is lower at areas deeper to the reflector. In the scan of the gallbladder above, the left side shows enhancement as described above. The right side shows decreased beam intensity because of attenuation in calcified gallstones. Enhancement is seen as an abnormally bright signal. This occurs when sound travels through a medium with an attenuation rate lower than surrounding tissue. Reflectors deeper than the weak attenuation are abnormally bright in comparison with neighboring tissues. The attenuation of the sound through the fluid in these tissues is less than that of the surrounding tissues and results in this abnormal brightness. Reverberation and ring-down artifacts are similarly recreated. Reverberation artifacts appear as multiple equally spaced lines along a ray line. Reverberation is caused by the sound bouncing back and forth between tissue boundaries and then returning to the receiver. Ring-down artifacts are produced when small crystals, such as cholesterol or air bubbles, resonate at the ultrasound frequency and emit sound. Because the sound is emitted after the initial reflection is received by the transducer, the system thinks the emitted sound is coming from deeper and deeper structures in the body. In a similar way, mirror imaging is a miscalculation the distance to the reflector. Here, if sound bounces off a strong, smooth reflector such as the diaphragm, the surface acts as a mirror and reflects the pulse to another tissue interface. The ultrasound system believes the second interface is beyond the first surface, and this is where it appears on the scan. In the case above, a mass in the liver just below the diaphragm appears mirrored above the diaphragm as well. One important artifact of propagation speed that is of Doppler includes aliasing. This occurs when the signal returning is too fast, takes too long to return, or if the speed detection setting on the machine, called the Nyquist limit, is set too low. In this case, red and blue colors mix, and you may lose recognition of the direction of flow. Other artifacts like ghosting and crosstalk are beyond our current scope and can be found in major textbooks of ultrasound physics. So, what we learned during this session includes how ultrasound images are made, how you can optimize the use of the equipment to show good quality images, and how assumptions in ultrasound lead to artifacts. One message to leave you with is that if you are ever lost, dealing with a new machine, or things don't look the way they should, then put one hand on the patient and one hand on the machine, and then find these three functions on the machine: 2D, gain, and depth. That should get you scanning with a good start. That is all. Thanks for listening to this lecture.